Hello my friends and welcome to my YouTube channel. This is an eye that underwent pars plana vitrectomy with silicone oil tamponade a little over 1 year ago, presenting significant posterior subcapsular and nucleus opacification. Cases like this one frequently feature adherent metaplastic cortex in the central posterior capsule, posing challenges in its removal due to the technical difficulty and risk of posterior capsule rupture. I'll present a technique in this video that is highly effective but which might be controversial: posterior capsule polishing with the Phaco tip. A perfect capsular axis should always be achieved, not only to ensure its benefits regarding safer nucleus management and lens effective position. A perfectly sized and centered axis is your safety net for an IOL sulcus implantation should the need arise. The nucleus is isolated by a nice hydrodelineation, and it seems to be a fairly dense one. This is the sweep and spin maneuver I developed to ensure complete cortex release from the capsular bag. I'm aspirating the peripheral anterior cortex to facilitate nucleus management. A traditional Phaco chop approach is a good technique choice for this small but dense nucleus. The isolated cortex epinucleus shell is easily managed, and the sweep and spin maneuver proved its value. The central posterior capsule presents significant adherent fibrotic tissue, a common issue in silicone oil tamponade cases. Upon evaluation of its aspect, I decided to remove it by rescraping and aspirating it with the Phaco tip. This is the PhacoPolish technique. Of course, the opacification can be left as is. However, if YAG laser capsulotomy is performed before the silicone oil removal, a significant amount of the latter could be easily migrate to the anterior chamber, potentially causing problems. Also, the opacification hampers fundus visualization, making the retinal status assessment, which is essential for deciding about and performing silicone oil removal, difficult. In this way, success in removing this opacification now would be a great bonus. Should the posterior capsule break during the maneuver, the silicone oil can be passively removed via the anterior chamber. This technique basically consists of scraping the posterior capsule with the Phaco tip facing down, making linear movements, maintaining the tip's face in the same plane as the capsule, and using very low fluidic settings. Vacuum is linear from 0 to 20 millimeters of mercury, and aspiration is also linear from 0 to 20 cc's per minute. Care is taken not to tilt the tip or lift it from the capsule with vacuum applied. A few too difficult to remove spots remain, which will pose no problem in the visual axis. One should know when to stop. IOL hydroimplantation is performed with all its advantages. Incisions stromal hydration is done preferably by directing the cannula aperture through the incision roof. The effective PhacoPolish technique provided an outstanding outcome, abbreviating the case management and visual recovery. Thanks for your presence here and staying until the end of the video. Please subscribe and don't forget to activate the notification bell